Everyone. Welcome everyone to TOPS, the Tobacco Online Policy Seminar. Thank you for joining us today. I'm Raymond Boyle, a tobacco policy researcher living in Minneapolis. As an aside, let me mention that there's some late-breaking news yesterday that Minneapolis City Council just approved a new minimum retail price of $15 for cigarettes, now the highest in the US. So some late-breaking news. TOPS is a free, multidisciplinary international forum for research with tobacco policy implications that use experimental or quasi-experimental study designs. This forum is designed to bring together academics, students, government employees, policy researchers, healthcare professionals, advocates, and funders. The goal is to break silos of tobacco policy research and provide a platform for high-quality research to be discussed and disseminated. TOPS is organized by Mike Pesco at the University of Missouri, C. Shang at Ohio State, Michael Darden at Johns Hopkins, and Jamie Hartman-Boyce at the University of Massachusetts Amherst. Today's seminar will be 1 hour with questions from the moderator and discussant. You're welcome to post questions and comments in the Q&A panel. And the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they're not read aloud. Your questions are much appreciated. Today's presentation is being recorded and will be made available along with the slides on the TOPS website. Again, that's tobaccopolicy.org. Now let me turn the presentation over to today's moderator, Mike Pesco, to introduce our speaker.
Today, we continue our Winter-Spring 2024 season with a single paper presentation by Annika Theodoulou entitled A Complex Evidence Synthesis Investigating the Effect of Individual-Level Smoking Cessation Interventions on Socioeconomic Inequalities in Tobacco Smoking. This presentation was selected via a competitive review process by submission through the TOPS website. Annika Theodoulou is a doctoral candidate in primary health care at the Nuffield Department of Primary Care Health at the University of Oxford. Her research interests include evidence syntheses, mainly focused on interventions for smoking cessation and weight management. Annika's doctoral research investigates socioeconomic inequalities in smoking cessation behaviors and outcomes to address health inequalities caused by smoking-related disease. Dr. Jamie Hartman-Boyce, Assistant Professor of Health Policy and Management at University of Massachusetts Amherst, is the co-author of the study and will answer select questions in the Q&A. Our discussant today is Dr. Meenal Patel, Senior Principal Scientist of Tobacco Control Research at American Cancer Society. Annika Theodoulou, thank you for presenting for us today.
Thank you. I'll just share the slides. Great. Can everyone see that? Perfect. I'm going to assume so.
Yes, we can.
Perfect. Thank you. So hi, everyone, and thank you for tuning into this presentation. My name is Annika, and I'm a doctoral student with the Center for Evidence-Based Medicine within the Nuffield Department of Primary Care Health Sciences at the University of Oxford. And today, as Mike said, I'm going to present the main findings from our Cochrane systematic review, looking at the effect of individual-level smoking cessation interventions on socioeconomic inequalities in tobacco smoking. The Cochrane Review forms part of my doctoral program of work, and I am supported by scholarships from the Society for the Study of Addiction here in the UK, the Rotary Foundation, and my college, St. Catherine's, here at Oxford. I've never received funding from tobacco, vaping, or pharmaceutical industries, and I have no conflicts of interest to declare. Two of my co-authors have grants or connections to pharmaceutical industry, but that's not related to the work I'm presenting today. I should also add that this work is currently under peer review, and as such may be subject to change and should not be circulated more widely at present. Being a Cochrane review meant that it was a very large project, which wouldn't have been possible without the contributions of all my co-authors and collaborators listed here, and in particular my supervisors, associate professors Nicola Linson and Jamie Hartman-Boyce. So over 6 million adults in the UK and nearly 12% of adults in the US smoke tobacco cigarettes. And as we all know, smoking is a leading risk factor for many devastating diseases, which places a heavy burden on individuals and healthcare services. But this burden is not evenly distributed. People from lower socioeconomic groups, so people with lower income or less education, are more likely to smoke. And this is a concern as tobacco kills up to half of its users, and consequently, least advantaged groups are more likely to live with and die from smoking-related disease. This makes tobacco smoking a major driver of health inequalities. Recognizing this threat to public health, here in the UK, the government set an ambition for a smoke-free 2030 with a focus on reducing variation in smoking prevalence between socioeconomic groups. Now, there's no safe level of tobacco smoking, so helping people quit smoking by managing the withdrawal symptoms through medication and behavioral support is vital. But despite comparable attempts and aids used to quit smoking, there's evidence that suggests that people from lower socioeconomic groups are half as likely to succeed in achieving abstinence. Now, as we know, smoking cessation interventions aim to manage the withdrawal symptoms when someone stops smoking. There are different types of medications and different types of behavioral support that can be delivered in various modes by different people in various intensities. So why are there these differences in smoking rates between socioeconomic groups, or in quitting success rather? Factors such as lower social support, lower levels of self-efficacy, social norms, or greater nicotine dependence experienced by individuals of lower socioeconomic groups may impose additional barriers to successfully quitting. Different stop smoking interventions will vary in their ability to manage these factors, so the same intervention might perform differently in different populations and contexts, leading to these differences in quitting outcome by socioeconomic group. So when deciding what interventions to provide, overall effectiveness of these interventions is crucial, and many Cochrane reviews provide high certainty evidence supporting the use of effective interventions to help people quit smoking. So, for example, from our recent component network meta-analysis, which looked at pharmacological interventions for smoking cessation, it couldn't differentiate between the effects of varenicline, cytosine, nicotine electronic cigarettes, or to a lesser extent, combination NRT, with all being effective to help people quit smoking. So if interventions are equally effective, it would make sense for decision makers to prioritize offering those that are least likely to perpetuate existing health inequalities. So for example, prioritizing those that are equally effective in lower and higher SES groups, or potentially more effective in lower SES groups to help address health inequalities caused by smoking. So this is what we set out to look at in this review, if there are any differences in effectiveness of these effective smoking cessation interventions by socioeconomic groups. So we followed Cochrane methods to investigate differences in the effectiveness of individual level smoking cessation interventions by socioeconomic groups to estimate the potential that an intervention might positively or negatively impact health inequalities due to tobacco use. And the protocol was published in the Cochrane Library before we started. So we searched the Cochrane database of systematic reviews from inception to May 2023 for Cochrane reviews investigating individual level smoking cessation interventions. We independently screened the characteristics of included studies within these reviews to identify studies that met our inclusion criteria. So what we were interested in was randomized controlled trials on adults investigating any individual level smoking cessation intervention of any intensity, which encouraged complete cessation of combustible tobacco cigarette use compared to no treatment, placebo, or another intervention. And studies must have investigated, either analysed or reported, the interaction between at least one SES indicator and the smoking cessation outcome at least 6 months from baseline. These studies should also needed to be, these randomized control trials should also needed to have been published after the year 2000. And we placed this lower limit for RCTs after the year 2000 for multiple reasons. One, to help ensure measures of socioeconomic position were most reflective in meaning across studies, because we know that SES can be considered a social construct and meanings behind different measures of SES have evolved over time. We also wanted to avoid introducing additional biases due to the greater likelihood of receiving additional unpublished data from authors of more recent trials, given we were planning to contact authors for more data as necessary. It also helped to limit screening of studies, that may have looked at interventions that are no longer available or appropriate in healthcare settings today. But this may have led to more recent relevant research being missed. So we followed standard Cochrane methods for screening, data extraction, and risk of bias assessment. So for those who are less familiar with Cochrane, they're a global non-for-profit which aims to produce and share up-to-date, accurate information to help facilitate decision-making in healthcare. The standard Cochrane Risk of Bias Tool 1, we use this to critically appraise the randomized control trials we included. And in this tool, it assesses all these domains listed here. But we did swap out selective reporting to look at, what we were interested in was looking at the availability of abstinence data by SES in the studies instead, as we thought this was more relevant to our research question. And for this domain, we judged it as complete information and therefore at low risk of bias if the data available was sufficient to include in the meta-analysis, and at high risk of bias if there was insufficient data to include in the study into a meta-analysis if appropriate. So studies here were each rated at low, unclear, or high risk for each of these domains, and then given an overall risk of bias rating as well. So the primary outcome we were interested in was smoking cessation rates between intervention and comparator groups, split by lower relative to higher SES groups at longest follow-up. And where possible, we calculated a ratio of odds ratio with 95% confidence interval for each study. These were then calculated, from natural log transform effect estimates. So the odds ratio for the treatment effect in the lower SES group and the treatment effect in the higher SES group. And where possible, we combined these by intervention type in a random effects meta-analysis using the generic inverse variance method. We pre-specified what we deemed as clinically significant based off cutoffs used in previous Cochrane reviews. For example, we considered the relative odds of quitting in lower compared to higher SES groups as a clinically significant increase when the ratio of odds ratio and confidence interval, for example, was greater than 1.05. We subgrouped by type of SES indicator and economic classification of the study country where we could. And we also ran sensitivity analyses, removing studies that were deemed to be at overall high risk of bias. We ran sensitivity analyses using additional SES indicators where a single study reported more than one. And we also ran sensitivity analyses looking at the adjusted estimates where unadjusted estimates had also been reported. So even with all these sensitivity analyses, there were a few, but I'm only going to mention them in the results today if they had a meaningful impact on the results. So they either changed the interpretation of the point estimate or the health equality impact rating. Otherwise, I won't mention them because there's probably not enough time. So we categorized the intervention impact on health inequality from positive through to negative. And for example, a positive impact on health inequality was defined as evidence that the relative effect of the intervention on quit rates was greater in lower socioeconomic groups So the point estimate favored lower SES groups, and the 95% confidence interval excluded no clinically significant difference. We classified it a possibly positive impact on health inequality when there was some evidence that the relative effect of the intervention on quit rates was greater in lower SES groups. For example, the point estimate favored lower SES groups, but the confidence intervals included the possibility of no clinically significant difference. So we also rated our confidence in the evidence used to produce the effect estimates for the main pharmacological and behavioral interventions compared to placebo control or a less intensive intervention. And we did this using the grade considerations listed here. We judged indirectness, so the one further here, by considering whether the studies contributing data to any given comparison were highly selective in terms of SES. For example, the studies had inclusion criteria limited to people living off a low income, for example. And the way grade works is that we start at high certainty, which indicates that we're very confident in the effect estimate. And this gets downgraded by each of these considerations listed here as needed to very low certainty, which then indicates very little confidence in the effect estimate that the data is produced. So we pre-specified in the protocol that for studies with more than 2 intervention arms eligible to be included in a single analysis, we included the study arms that were most and least intensive in the analysis and narratively reported information of any additional study arms from that study in the text and in the table. Similarly, for SES indicators that had more than 2 categories, for example, education level may have been classified as high, medium, and low. We compared the categories at each end of the scale for the primary analysis. As I said, to deal with missing data, we contacted study authors, and we also presented all the data in effect direction plots. So I'll pause here and open up for questions before I move on to the key findings.
Thanks so much, Annika, for your presentation so far. Very interesting. First, we will take an opportunity to hear from our discussant, and please enter your questions in the Q&A, and we will return to those after discussant comments.
Thanks, Mike. And Annika, thank you so much for setting up your study and talking through in detail. I think this topic is extremely important, looking at health inequalities and trying to figure out a way to help reduce the burden, especially amongst low SES individuals, is very important and should be a priority in a lot of the work that we do. I did have a question conceptually. Why did you choose SES as the factor for health inequalities that you were examining? Why not other factors? You mentioned some other moderators and covariates, but SES is one factor of health inequalities. Did you consider other measures?
That's a good question. It is the focus of my PhD, was to look at socioeconomic inequality. So it very much defined that for this review. Even within socioeconomic inequalities, or even just measuring that, there's just so many different ways it could be done within that domain alone. We didn't consider other variables that are also impacting that. We did note when we were preparing the protocol that things like ethnicity and race would potentially have, but that was all we were able to do really was collect that descriptive information from the studies that we had, but weren't able to analyze it further within the scope of this review.
Yeah, that was my next question of, did you consider looking at, maybe separating out the effect of race and SES, because we know that race is an important factor and it comes with this background of racism, et cetera, in various countries. And then this goes to the next piece of how does SES and the measurement of SES vary across the different countries in which you've looked at some of the studies for?
That is a really good question. So for the review, we considered an SES indicator as defined by the studies themselves. And there was obviously, as you'll see in the slides going forward, many different ways this was measured. And in the protocol to account for this, we had the other option. So if a study had used something completely different we hadn't thought of, but we didn't pre-specify in the review, we were still able to include that study and look at it, because in other countries, there are definitely other ways in which SES can be measured. In the US, a lot of the US papers, for example, used health insurance and benefits as an SES indicator, and that wasn't something we'd thought of at baseline in the protocol to include. So yeah, to account for that, this was a review looking at studies from all over the world, and we were interested in any measure of socioeconomic status as defined by the studies themselves.
And moving forward, I know you'll discuss this in a little bit more detail, but how do you think it impacts your comparisons and taking a look at the overall impact of SES to have these various measurements?
So I think it really depends on the interventions that we're looking at specifically, and it did have an effect for some of them. And that's why we did those sensitivity analyses. If studies reported more than one SES indicator, it allowed us to explore how it varied between different measures of socioeconomic status. And for some of the comparisons, it did have an impact. So yes.
Right. And I know you'll speak to this in a little bit, so I'll let you get to that in just a moment. The last question is, again, more of the conceptual. And I know that the Cochrane reviews tend to focus on randomized control trials. They are the gold standard when we talk about examining impacts on various populations to have this control group. What area do you think the role of observational studies lies in this? And would you have considered a parallel analyses of these same questions, but looking at not just randomized control trials?
That is a good point. I suppose because we have focused on randomized control trials, it means we're looking at evidence in trial settings, not in real world settings, which that observational studies would provide insight into. My second project in the doctoral program of work is looking at observational data and different measures of socioeconomic position. So that is just a limitation of this review. But yeah, it is standard practice in Cochrane to use the highest level of evidence, which are randomized controlled trials. But that's not to say that observational data does not have an important role when investigating this topic.
Yeah, I would argue that it does have a very important role, which you are going to be examining in your second piece of your dissertation. But, you know, the randomized control trials give us a good base of evidence that is very strong, but what's happening in the real world is also important. And so putting these pieces together is critical before we make these larger conclusions, which I believe you'll speak to as well in this presentation. And so I think as our participants are going through your results, it will be important to think through, like, how does this fit into the real world, especially when we're talking about interventions that impact those who may be the most vulnerable or have the lowest source of resources. And so I think that's a good lens in which to view some of these findings, which, not to be critical of randomized control trials, again, they're fantastic, but there are limitations to all types of studies, and that is one of them, which I think you will speak to as well. So thank you, Annika. I don't want to keep going. I can ask the rest of my questions at the end, but I think this was a great way to set the stage for your findings. So thank you.
Great. Thanks very much for the questions. I'll move on to some results. So just getting that up there. So our database search identified 290 non-duplicate Cochrane review records. And of these 290, 57 Cochrane reviews reported on individual level smoking cessation interventions. We screened the descriptions of the 2,511 studies listed in the characteristics of included studies tables within these 57 Cochrane reviews for eligibility. We retrieved 2,677 non-duplicate full text articles. And it was about here where I emailed over 700 study authors directly to query whether they had conducted any additional analyses on the SES indicators that they had happened to report at baseline. I received over 170 responses from study authors, and some of whom are potentially very likely in this room. So thank you very much for those responses. And again, after removing duplicates, the main reasons for exclusion of full text was either study authors reported collecting SES indicators at baseline, but did not report on or confirm any additional analyses were undertaking investigating the interaction effect of an SES indicator and treatment variable on smoking cessation at 6 months or longer. So we included a total of 77 studies and identified one ongoing study, which met our inclusion criteria. And I did email another handful of authors for additional data there. So thanks for responding to those emails. So of those 77 included studies, they represented over 120,000 randomized participants. Now, the number of participants analyzed varied depending on the SES indicator and how SES was categorized. The 73 of the 77 studies were conducted in high-income countries, including 36 from the US, 10 in the UK, 8 in the Netherlands. 3 studies were conducted in upper middle income countries, including 2 in China and 1 in Turkey. And 1 study was conducted across 2 low middle income countries, Bangladesh and Pakistan. So the majority of studies, 35, included samples where the predominant ethnicity was described as white or Caucasian. 46 studies recruited people who were motivated to quit smoking, while the remaining 31 studies did not recruit participants based on their motivation to quit. 16 studies restricted inclusion based on a measure of socioeconomic status. So for example, they may have limited inclusion to people living on a lower income. And lastly, 33 studies restricted inclusion to a particular population characteristic. So they may have specifically focused on people with a particular chronic condition or young adults, for example. So the included studies investigated a range of pharmacological interventions, behavioral support, or combinations of these two, and some of them are listed here. All studies measured smoking abstinence at 6 months or longer from baseline and intended to analyzed or presented quit rates by an SES indicator. Education was the most common SES indicator used, reported in 66 of the included studies. We judged 12 studies to be at low overall risk of bias, 13 studies at unclear overall risk of bias, and the remaining 52 studies were at high risk of overall risk of bias. The majority of these studies were at low risk for all domains except our availability of smoking abstinence data by socioeconomic status here. And 34 of these studies were rated at high risk for this domain as there was insufficient data reported or made available upon request to include in analyses with a lack of detail, potentially due to the lack of association detected. 8 studies were rated for this domain were rated at unclear risk of bias as authors collected multiple SES indicators and reported data for some, but not all of these SES indicators without pre-specifying any intention to specifically limit looking at this interaction for specific SES variables. So they were rated as unclear. Now the results. So focusing firstly on the pharmacological and electronic cigarette intervention comparisons. This diagram here summarizes all the intervention comparisons we were able to find evidence on for these pharmacological interventions. It shows the number of studies favoring high SES, low SES, or no differential intervention effectiveness by SES, and the impact on health inequality, ranging from negative through to positive for every intervention comparison. So if I look more closely, focusing on NRT, and looking at the figure from the bottom up, there were only 1 study that each contributed to the comparisons looking at offer versus no offer of free NRT, NRT tester period plus patient selected NRT versus usual care, or 16 versus 8-week duration of combination NRT. Now, all indicated a possibly neutral, no difference, or unclear impact on health inequality. Now looking at preloading, so 3 studies provided pre-quit NRT, so nicotine preloading, as well as post-quit NRT. However, lack of data and the differences in the intervention where data were available precluded our ability to pool this data in a meta-analysis. 2 studies found a possibly negative impact on health inequality, and 1 study reported no interaction effects of the intervention on education on quit rates and education on quit rates. Now, we weren't able to pool these 2 studies with data because the intervention for one of the studies varied a little bit in that participants were told to reduce their cigarette consumption rather than outright quitting, which was what was advised in the other study. So they were not pooled even though there was data available. Great, so now looking at combination versus single form NRT. For those of you who aren't familiar with the forest plot that I've just brought up on the screen now, these are a graphical representation of a meta-analysis. Now, the line in the middle here is the line of no effect, and it indicates no clear difference between the study groups. Each row represents a study, and with the square at the end of that study line indicating the effect estimate, and the lines on either side of that displaying the 95% confidence interval. Now, the size of that square indicates the influence an individual study has had on the pooled result. So a bigger study with a narrower confidence interval will be given greater weight. And now the pooled estimate is the center of the diamond here represents the pooled estimate, and the points, the horizontal points of that diamond depicts the confidence interval. So when we're looking at this forest plot here, we can see that pooled data from 4 studies showed a possibly positive relative effect of combination NRT versus single form NRT on quit rates in lower compared to higher socioeconomic groups. The confidence interval included the possibility of no clinically significant difference and of favoring higher socioeconomic groups. There was moderate statistical heterogeneity was observed due to 2 of the 4 studies demonstrating effects in opposing directions to the other 2, but confidence intervals did overlap. Sensitivity analysis was run using an alternative single form NRT arm for some of the studies, in addition to removing 3 studies judged at high risk of bias, but these did not change the interpretation of effects. And I won't mention that again moving forward, but just to explain, there was sensitivity analyses conducted here, but they had no meaningful effect on the result. So we have jumped ahead, sorry. There we are. So 2 studies compared single form NRT to placebo. 1 study indicated a possibly negative impact on health inequality, while the second narratively reported no statistically significant interaction between SES and the intervention versus comparator. Looking at combination NRT, pooled data from 2 studies showed a possibly positive relative effect of combination NRT versus control on quit rates in lower compared to higher socioeconomic groups. The confidence interval included the possibility of no clinically significant difference and of favoring higher SES groups. There was substantial heterogeneity observed with these 2 studies, with the 2 studies each demonstrating opposing directions of effect, but with overlapping confidence intervals. 1 of the studies was judged at high risk of bias, and removing the study changed the direction of effect, but confidence intervals remained wide, including the null. 2 studies compared bupropion to placebo. 1 study indicated, get it up here, 1 study indicated a possibly negative relative effect of bupropion versus placebo on quit rates in lower compared to higher socioeconomic groups. And the other study confirmed that there was no statistically significant interaction between education level and treatment arm on quit rates, which was narratively reported. Looking at now bupropion and NRT versus NRT alone, 4 studies compared bupropion and single form NRT to NRT alone. The pooled estimate for 2 studies indicated a possibly positive relative effect of bupropion and lozenge, NRT lozenge, versus NRT lozenge alone on quit rates at at 6 months in lower compared to higher SES groups, and removing the one study judged at high risk of bias for this comparison changed the relative effect on health equality to possibly negative. When comparing the relative effect of bupropion on lozenge versus patch alone, which was another eligible study arm for 2 of the studies, the same 2 pooled studies suggested a possibly neutral impact on health equality. However, this changed to possibly positive when one study judged at high risk of bias was removed. Now, the narrative findings from the 2 other studies reported no statistically significant interaction effects between an SES indicator and bupropion plus NRT versus NRT alone, but the directional effect was not available for these 2 studies. Finally, looking at nicotine receptor partial agonists, and firstly cytosine versus placebo. There was one study and it showed a possibly positive relative effect of this nicotine receptor partial agonist on quit rates and lower compared to higher socioeconomic groups. However, confidence interval also included the possibility of both no clinically significant difference and of favoring higher SES groups. This study was also conducted in adults with pulmonary tuberculosis living in a lower middle income country. There was no studies on varenicline versus control that looked at SES indicators by study arm. Now looking at electronic cigarettes, one study each compared, looked at nicotine electronic cigarette versus NRT, and nicotine electronic cigarettes versus non-nicotine electronic cigarettes. Both showed a possibly positive relative effect of the intervention versus comparator on quit rates and lower compared to higher socioeconomic groups. However, the confidence intervals also included the possibility of no clinically significant difference and of favoring higher SES groups. And here are the forest plots here. That's a bit nicer to look at visually. So, 3 studies compared bupropion and single form NRT to bupropion alone. The pooled estimate for 2 studies indicated a positive relative effect of bupropion, possibly positive relative effect of bupropion on losses versus bupropion alone. Sorry, a positive, just positive intervention impact on quit rates and lower compared to higher SES groups. Removing the one study judged at high risk of bias shifted the relative effect on health inequality from positive to possibly positive, with the direction of effect remaining the same, but the confidence interval including the possibility now of no difference and of favoring higher SES groups. There was one study that reported no differential effects when they examined interactions between treatment and 2 SES indicators, but the direction of effect again was not reported for this study. Now moving on to behavioral interventions. Again, here is the overall figure of all the comparisons that we had evidence for, but looking more closely, specifically starting with print-based self-help materials. Pooled data from 3 studies showed a possibly negative relative effect of print-based self-help materials compared to no materials or balanced treatment. And by balance, I mean the intervention component was balanced between the 2 study arms. A possibly negative impact on health equality. More versus less print materials. There were 2 studies which were pooled, which showed a possibly positive relative effect of more versus less print self-help materials on quit rates and lower SES groups. The confidence interval also included the possibility of no clinically significant difference and of favoring higher SES. Lastly, looking at tailored versus non-tailored self-help materials, the pooled estimate for the 3 studies indicated a possibly neutral relative effect of tailored versus non-tailored material on quit rates and lower compared to higher SES groups. The confidence interval included the possibility of favoring both higher and lower SES groups. Now, we were able to run sensitivity analyses on this, which increased the pooled estimate, and indicated a possibly positive impact on health inequality, while removing one study judged at high risk of bias decreased the effect estimate, suggesting a negative impact on health inequality. So a bit of inconsistency there. Now, looking at telephone counselling versus no treatment, minimal or balanced components, there were 7 studies that looked at this, and overall, 1 study indicated a positive impact on health inequality, but the remaining 5 studies reported no relevant significant interactions, and findings from 1 other study were unclear. So in that study, they had intended to look at SES, but there was no extractable data at all. 6 studies compared face-to-face individual counselling to less intensive face-to-face counselling, balanced components or usual care. Overall, 1 study indicated a possibly positive impact on health inequality, while the remaining studies reported no interaction. Again, this was narratively reported. 4 studies compared text messaging, stop smoking support to no treatment or self-help materials. The pooled estimate for 3 studies indicated a possibly negative relative effect of text messaging versus no or minimal treatment on health inequality. However, the confidence intervals again included the possibility of no clinically significant difference and of favoring lower socioeconomic groups. There was no evidence of subgroup differences between the studies from high compared to upper middle income countries here. And the direction of effect for each subgroup went in opposing directions. However, the confidence intervals did overlap, which you can see in the forest plot below. 1 study included 3 intervention arms, with the most and least intensive arms, so that would be high frequency text messaging versus control, was included in the primary analysis. But when we compared the low frequency text messaging, which was the middle intensity arm, to control, the directional effect did change, but confidence intervals again remained wide. Lastly, the corresponding author for the study, Hung 2013, confirmed that there was no moderating effects when they looked at education level on quit rates, but weren't able to provide any further data beyond that. 5 studies compared tailored interactive internet interventions to a static website, no intervention or balanced components. 1 study showed a possibly positive relative effect of the intervention on health inequality. However, confidence intervals also included the possibility of no difference. The 4 remaining studies reported no interaction effects between SES indicators and study group on quit rates, with no further information on the direction of effect reported. Finally, 6 studies compared a stop smoking intervention with financial incentives to the same intervention without financial incentives. Now, the pooled estimate for 5 studies indicated a possibly negative relative effect of financial incentives on health equality. However, confidence interval also included the possibility of no clinically significant difference and of favoring lower socioeconomic groups. There was no indication of subgroup differences. However, the direction of effect for 2 of the studies that measured level of deprivation in pregnant participants showed a positive relative effect on health inequality, while the directions of effect for studies using other SES indicators favored higher SES groups. A sensitivity analysis using a second different measure of education that was reported in 1 study, ETA 2016, increased the pooled point estimate to indicate a possibly mutual impact on health inequality. However, again, confidence intervals remained wide. Further sensitivity analyses had no interpretation on these findings. Now, there was 1 more study that looked at financial incentives, and they reported no significant interaction effects between study group and SES indicator for any of the SES indicators they looked at on abstinence outcomes, but there was no further information beyond that. Here are the list of all the other comparisons we had some evidence on, but I don't have time to touch on today into any great detail, but I will be around for the top of the tops if anyone has any questions about these. Now in summary, so I'm focusing on our summary of findings for the main intervention comparisons for which we undertook that grade assessment, our confidence in the effect estimates that we've calculated. Now looking at the pharmacological and electronic cigarette interventions, evidence on cytosine and nicotine electronic cigarettes compared to control indicated a possibly positive impact on health inequality, with a greater relative effect of these interventions on quit rates and lower compared to higher socioeconomic groups. We also found a possibly negative impact on bupropion compared to placebo, as I said earlier, on health equality. The intervention impact of combination or single form NRT on health inequality couldn't be determined from the evidence available, as I sort of talked through earlier. It all varied quite a bit. And we found no studies on varenicline versus control. Now, the evidence for each of these comparisons was downgraded to very low certainty for all of them due to indirectness, high or unclear risk of bias for all comparisons, imprecision due to wide confidence intervals or few studies contributing to that comparison, and due to inconsistency. So where directions of effect of studies included in a single comparison went in opposing directions. Now focusing on the summary of findings for the behavioral interventions, we found a possibly negative impact of print-based self-help and text messaging interventions versus control and health equality, indicated by a lower relative effect of each of these interventions on quit rates and lower compared to higher socioeconomic groups. We found a possibly negative impact of financial incentives when compared to balanced intervention components on health equality. We found a possibly neutral health equality impact of face-to-face counselling when compared to less intensive counselling or usual care, and a possibly positive impact of telephone counselling and internet interventions versus control. Again, when we applied the grade assessments, we found low to very low certainty for all of these behavioural interventions. Print-based self-help, text messaging, financial incentive comparisons were all downgraded 2 levels due to imprecision, so wide confidence intervals. Financial incentive comparison was downgraded due to indirectness, so some of the study samples selected included participants based on an SES indicator. Face-to-face counselling and telephone counselling were both downgraded 2 levels, as all studies were at high risk of bias, and 1 level for imprecision. And internet interventions were downgraded 1 level due to imprecision. Again, the confidence intervals for those studies were just not reported for most of them, and 2 levels due to most studies being at high risk of bias. So there were some limitations of this review. We conducted the review in accordance with the Cochrane methods, which are widely accepted as robust and best practice. However, despite the rigorous process, we undertook the nature of our objective and the topic overall may have led to the persistence of potential biases. For reasons of pragmatism, our electronic search for identification of studies was through screening included studies within Cochrane reviews on smoking cessation interventions, which has been done before to manage a large topic in other Cochrane reviews. So although our search for these reviews had been updated to May 2023, the searches for studies within the reviews were conducted earlier and potentially leading to more recent studies being missed in this review. However, we tried to counteract this because we did email a lot of study authors who are experts in the field, and this did lead to the inclusion of at least 1 study that was newer, which we hadn't originally identified through our review process. And obviously, being a systematic review, the goal is to identify all the available evidence to address the research question. So many study authors responded to requests for additional data, for which we are very grateful. However, in many instances, the numerical data was no longer attainable despite best efforts, and narrative findings were reported. Despite the comprehensiveness of the review, subjectivity and differences around defining, measuring, and reporting of SES indicators in this field limit the conclusions that we can draw. There's no universally accepted definition for low and high socioeconomic status, and it can be measured by many different types of indicators across studies, across countries, as our discussant mentioned earlier, which may also vary in meaning, again, across time and context. So in this review, we were interested in the relative difference between lower and higher SES groups, and pre-specified to compare data from each end of a scale where there was more than 2 categories describing a difference within a single SES indicator. This was a subjective decision which resulted in the exclusion of some data from studies that broke down SES into more than 2 categories. We also pre-specified a preferential list of SES indicators to include in the primary comparisons for studies considering multiple SES indicators. But as I said, we did run sensitivity analyses to investigate the effect of these choices on our interpretation of results. Again, as was brought up earlier, this review investigates evidence in trial settings, and participants who volunteer in these settings may not be generalizable to the wider demographic. So getting to the conclusions, currently there is no clear evidence to support the use of differential individual level smoking cessation interventions for people from lower or higher socioeconomic groups, or that one intervention would have an effect on health inequalities. However, this conclusion may change as further data becomes available. Further randomized controlled trials on individual level smoking cessation interventions should collect, analyze, and report quit rates by socioeconomic status using SES indicators, but also by randomized study arm to inform intervention development and ensure recommended interventions do not exacerbate but help reduce health inequalities caused by combustible cigarettes. Further RCTs on these interventions would also be useful, particularly outside of high-income countries. These are needed to strengthen the evidence on the impact of these interventions on health equality. As I mentioned, the Cochrane Review was the first project in my doctoral program of work. And again, this review focused on evidence in a trial setting, while my second project will explore smoking and quitting behaviours by socioeconomic position in England in a real-world setting. So the second project builds on this work by using population-level survey data to explore associations between different measures of socioeconomic position and cessation behaviours and outcomes. So I'm going to be focusing on smoking prevalence, motivation to quit, level of tobacco addiction, quit attempts, use of cessation aids, and quitting success overall. And lastly, I'm going to be doing some in-depth interviews with people from lower socioeconomic groups to explore factors that may influence uptake, use, and success of smoking cessation interventions. Thank you very much for listening through all those results, and please feel free to ask me any questions.
Okay, thank you, Annika. Please continue to enter your questions in the Q&A. We have 8 minutes remaining, and I will turn it over to our discussant for further comments.
Thank you, Annika. This was a tremendous amount of effort that you all have put into in looking at these various studies, and it is commendable because there are so many different varieties of interventions. And so I appreciate you breaking it out by pharmacological and behavioral. We do know from the science that multiple interventions are needed oftentimes for an individual to successfully quit. Like most individuals have more than one quit attempt until they're able to successfully quit. And oftentimes it's a combination of both behavioral and pharmacological. Were you able to look at these combination randomized control trials and piece out what portion actually like what effect those had in comparison? I know you mentioned you had done many other intervention comparisons, so can you speak a little bit about these multiple strategy interventions?
Yeah, so there were definitely, sorry, you can still see my slides maybe.
Yeah.
I did just scroll back. I have focused on the sort of cleaner comparisons to present today, but there were definitely evidence that we were able to summarize at the very least that looked at a combination of pharmacological and behavioral stop smoking interventions. Off the top of my head, I can't, I can quickly have a look and see what we found for those. Sorry, I don't mean to.
No, it's
that.
okay.
Just to give you an idea of what we found. So behavioral support and NRT versus usual care minimum or less intensive behavioral support. So again, that's a combination of pharmacotherapy and behavioral support. For this particular comparison, there was a possibly neutral impact on health inequality. So that affects estimate, suggesting it potentially, a possibly neutral impact at 1.03. There was a whole lot of other interventions that we looked at, so multi-component interventions, and we grouped them together in more intensive versus less intensive multi-component interventions. Again, we just summarized these because they weren't able to be pulled together. They were just too different, essentially, but more information on each of those is available in the review. I'm sorry, I can provide more detail than that right now.
And I know we're short on time, so no need to go back to other interventions that you've reviewed, but I think it's a really interesting piece that you've looked at so many various comparisons to really see. One of the things that I find very striking is that we are looking at these studies in various, as you mentioned, high income countries. So we don't know what the impact would be on low income countries. However, even within these high income countries, the policy environment varies tremendously. And so we know that in some countries, for example, e-cigarettes can be considered a pharmacological device, whereas in other countries like the US, we know that they're available on the free market without having gone through the randomized control trial process of whether they're effective or not. And so I wonder how much of these findings are applicable across countries and whether it would be important to take a look by policy environment or countries and seeing how you may see some differences or not.
That would be very interesting to look at. I think I did mention we did attempt to do subgroup analysis by economic classification, income classification of the country, so high income versus lower income countries, but the data wasn't there for us to really be able to do that beyond, I think, one comparison. You mentioned, like, I suppose in the review, we were looking at the relative effect of a higher versus lower SES group within a population that would be exposed to the same regulatory population level intervention. So I hope that has less of an impact. But I suppose, as you say, it could be, and it would be something very interesting to look at, but that is, I don't think the data is there to be able to do that within these studies that we were
right,
looking at
especially
anyway.
In cases where you have 1 to 2 randomized control trials that you're looking at within a certain condition. I think one of the bigger concerns I have is the implications that these findings would have may vary across policy environments. And I do think that you know, in high income countries, there may be more homogeneity versus low income countries, and you can't necessarily take a look at that with these data. But even within these countries, I wonder if the interventions may vary in their efficacy as well as the impact on health inequities.
As in, you think that the interventions themselves will vary because of the external factors within a particular country. That I probably can't comment on too much. I'm not particularly sure, but that is a very good point. Do electronic cigarettes in one country, are they more effective than in another? I'm not too sure. I'd need to look back at the literature on that. But that is an interesting question.
I have many, many more questions, but I know we're close to the end. I think Mike might be able to ask one quick question, so I'll give the floor to him. But Annika, thank you so much for a great presentation.
You're muted, Mike.
Thank you. I think I'm going to pass it on to Raymond to take us out the door, and we'll continue the discussion with top of the tops.
Great. Thanks, Mike. Yep, so we are running out of time. However, we do want to continue the discussion. So in the top of the tops group discussion immediately following, there'll be a chance to for everyone to join us. We'd like to encourage everybody. The URL can be copied. It's bit.ly/topsmeeting. I'd like to just thank the presenter, and Annika, thank you much, and the moderator and discussant. Finally, thank the audience of 153 people for today, and I'd love to see you all in the discussion and have a nice weekend. Thanks very much.